Okay. All right. Well, it's just up on the hour. We have a very, very full agenda, so I'm going to go ahead and get started. My name is Christine Rygroth. I'm the current chair for the Leadership SIG Advisory Group. We are recording, so just FYI, please be aware we are recording. We had a call last year, and we had a lot of problems with some technical problems and some beeping. We think we've solved all those. So just to give everybody a little bit of background, at conference this last year and in conversations we've had on the advisory board after conference, there's a lot of interest around, different models around Acuity, and how you manage staffing in relation to Acuity, and there's a lot of aspects of this, and it truly is a topic that's bigger than a bread box. So we were trying to define it down to a manageable approach to discussion where we could really move the conversation forward. And what we decided to do was really just to extend the dialogue to people that have expressed interest at the conference and then in an email on our community site. So we have 4 speakers who are going to speak to us today. They've put in quite a bit of work on these presentations, and we hope to have some conversation at the end where we can talk as a group and think through, are there areas that we need more for, or is it best to just share different models so that you can kind of take the things that are applicable to your organization, so we need to get as much information on a variety of topics, or is there an area of focus where we think we might be able to move the ball? So we've got a very full day for you today. It should be a good conversation. We will be recording on Monday. I'll put a posting on our community board for the Leadership SIG in general to listen to the conversation. I'm going to turn the call over to Diane Resnick, who is going to give you some instructions on the call and how to ask questions as we go. I'd like to just take a moment and from the Leadership Advisory Board, just to thank all of you who have expressed an interest and who are on the call today. It's much appreciated, and your inputs and thoughts are greatly appreciated. So thank you all very much for your participation. At this point, let me turn the call over to Diane.
Okay. Right. Hi. So our participants today will be providing a brief overview of the different methods to approach the subject of acuity, workload measurement, and staffing models. So as Christine said, we hope that this will start further discussion and be a stepping stone to future research on acuity and workload measurement. So our speakers are as follows. Nancy Fortgang is the Associate Director at Yale New Haven Health in Connecticut. Her presentation will focus on a proposed ambulatory acuity system based on service needs, resources, variables, and clinical diagnosis in order to formulate a level of complexity. Our next speaker will be Pam Del Monte, who has held a variety of roles in ambulatory care. Her presentation is a brief overview of information that will be included in the upcoming AAACN orientation and competency test on nursing workload. Our third speaker is Mike Callahan, who is the Director of Nursing from James Cancer Center, part of the Ohio State University Wexner Medical Center. He will be joined by Jenna Butts, who is a data analyst, and their presentation will focus on the project of standardizing staffing models. And Stacy Clark is the Assistant Vice President and Associate Chief Nurse Executive for Ambulatory at University of Texas Southwestern Medical Center in Dallas, Texas. Her presentation is an overview of a project she is leading to capture workload time estimations and to help determine staffing requirements. So now I'm going to turn it over to Cynthia Murray, who will provide directions as to the process and use of our WebEx.
Good afternoon, everyone. So on the WebEx platform, there's a couple of things that we'd like you to utilize. Up on the top of your screen, probably over to the right, you're going to have a drop-down bar and a show chat somewhere in that area. click on that so that the chat is on your screen. So you're ready to ask a question of the speaker. And those questions will not be asked during the presentations or immediately after. We will have time for all questions at the very end of the presentation in total. And they will be read to the speakers by myself so that we can get a few questions in for each of the speakers with the limited time that we all have. Those chat, though, will be saving all those questions so that we can get back to you on those on your needs and have the directors. The speakers directly respond to you. In saying all that, we need all phones to be muted. Every phone to be muted so that the speakers will be able to have time to speak and no interruptions. So without further ado, we're going to begin our program today with Nancy. And give me one moment, and we'll have Nancy up and ready to go. Nancy, you still there?
I'm here.
You're doing good. I knocked you out.
There you go.
Yep. Okay, let's make it big. All right, Nancy, 2 seconds.
All right. Perfect. Well, hi, everybody. Good afternoon. Happy Friday. It's a really beautiful autumn day here in New England, so hopefully you're having some good weather as well. I thought I would get started by putting a little bit of context around the presentations today. I'm going to start with really more of a global approach. And you can go to the next slide, Cynthia. I'm really looking at more of a global approach to quantify nurse work. And the next few presentations will be more specific work about metrics and some different models as well as their progress and data to date. So, as with many organizations, honestly, today I feel like all roads lead to money. It's all about savings and costs and expenses and budgets. And over the past few years, I have found myself really struggling to find data to support, RN FTE staffing requests. I work in a big university, and often I feel like I have to sell my firstborn in order to get us a staff, a new addition to the team. And it's really been much of a struggle to find some data. Lots of organizations have benchmarks, and we have information about panel sizes and, registries and ratios for various models for different practices, but it was really hard to find a standard process to support my specific FTE requests. Nursing clearly has evolved. Patients are sicker. Ambulatory nurses, is very different than it was back in the day. And so I was fortunate that I had a very engaged team. And we began some conversations, and it was really about how do we document and how do we find the data that we need. Okay, next slide. So just quickly, a little bit about who we are. Yale Health is a staff model managed care facility, and we are associated with the Yale New Haven Health System. We are kind of unique in that we're both provider and payer. We have 40,000 members, provide specialty and primary care. We also have 24/7 acute care, as well as a small inpatient unit. Next slide. So what we really set out to do was to standardize the process to quantify both the value of a nursing intervention as well as to create a metric to quantify time and complexity. We needed data. It needed to be reportable. It needed to be something that we could continue to, standardize across all of our settings. We wanted to create some definitions and a shared language. Next. In essence, we were looking for a tool to measure acuity for the ambulatory setting. We wanted to plan resources accordingly, to standardize triage assessments, to support staffing needs and requests, and ultimately to optimize outcomes. So what tools are actually, were there any tools really available already? Some of you may be familiar with the ESI, or the Emergency Severity Index. It's a tool that's been in existence for quite some time, and it's widely used around in emergency rooms and urgent care centers. Essentially what it is a stratification of patients and helps emergency rooms categorize ED patients both by acuity and, most importantly, resources. Next slide, please. So, you know, this is an evidence-based system that prioritizes the delivery of care. Excuse me? I'm sorry, I'm hearing just a little bit.
Can everybody please go on mute during the presentations? Please put your phone on mute. Thank you. Please go on mute.
Okay, so the ESI is a tool that standardizes acuity levels across EDs. It is an evidence-based system that prioritizes the delivery of care, and equally as important, the use of resources. For an example, a trauma patient obviously requires many more staff and resources than a patient presenting with a simple knee injury. So we were kind of, stumped a little bit and wanted to, consider, could we create a similar tool for the ambulatory setting? And we decided we would need to consider how many services were required, how many resources were required to complete an encounter, and how other variables influenced RN work for each specific nursing encounter or nurse visit. And essentially, we wanted to create an algorithm that would factor in services, resources, variables, with the appropriate weighting of each component, add in the diagnosis, time spent to identify a complexity level. So the next slide says, determine that we would kind of come up with some definitions and our shared language. We defined a resource as any additional consultation, department, collaboration, or diagnostic support that was required to complete that visit. Some examples would be a consultation from a specialist, or labs, imaging, pharmacy support, complex care, coordination, and management. What is a service? On the next slide is defined as any nurse-specific work beyond the standard assessment that is required to complete that encounter or RN visit. This might include significant patient education, self-care, teaching someone how to administer insulin, teaching family, having a family visit, having extensive medication reconciliation or review or consolidation. These services, what I call, are beyond just a routine nurse visit. There takes lots of time, complexity, how much after visit was required, how much, what we call follow-up time, and was it significant? And of course, there are so many other factors and variables sort of in this big, large bucket that impact any assessment. So we sort of grouped those as well. Was this, for example, a red flag? Was it this is a high acuity call or a high acuity walk-in patient? Were there language barriers that impacted this visit? Cognitive barriers? Was age an issue? Were there, transportation issues or family or financial influences? Was this a transitional care patient? Were they in and out of many EDs along the way? Did we need to figure out and add all of that in? Were there behavioral issues? Did they live alone? So lots and lots of issues that impact each RN visit. And what we decided that we would try and keep it simple, and we identified 3 levels of complexity, low, moderate, and high, each with their own values. And obviously, as you sort of go through this, you would, each call or each encounter would have a number of resources, a number of services, a number of factors and variables. We would add that plus the time or duration spent, plus diagnosis, and with appropriate weighting to each variable or service or resource, come up with some kind of a number that would fall on a scale or what we would be calling an acuity scale. Next slide. So how do we do this? Sounded simple. We wanted to just go off and do it, but it was really quite the challenge. Again, we really didn't want to add work to our nurses' plates. They're already really busy and doing many things that really they don't need to even be doing, but it's part of the role. So we wanted to create some sort of coding process, perhaps, behind each counter, similar to the process that we do. I think I've lost my screen. Do you all see it? Is the presentation still going?
Yeah, we can see you.
Yes, it is.
Okay. Sorry, I'll just keep going. So, you know, we wanted to create some kind of a process that was an algorithm that would be behind the scene. Not too much different than a coding process is done now. Could we compile enough data to identify acuity levels of patients? Would we, in fact, be able to correlate higher complex acuity levels with staffing needs? And if we adjusted nursing support according to acuity levels in departments and populations, would it, in fact, impact ultimately outcomes and perhaps even costs? So that was sort of our dream big. Interestingly, many of us focus on saving and reducing costs, but really equally important is the focus on cost avoidance. The value of an RN intervention could be correlated by keeping patients healthier, avoiding ED visits, noncompliance, providing care at the right place at the right time, saving unnecessary visits, office visits, impacts of hospital readmissions, reviewing meds could lead to prevention of medication errors and ultimately a sick visit. And it's really the potential downstream to avoid costs. It was very hard for us to articulate and how the impact of the RN, what they had on that. So at this point in our discussion, I'm really basically interested to know if this resonates with others. Is there any logic here that we feel that we can grow or wrap our heads around? Can we get some consensus on some of these pieces? Is this the journey worth taking? Because really, in my mind, I feel that in order for this to be effective, it has to be a consensus. It has to be a standard tool similar to what they use in the ED, which is pretty much a national ED, which is a tool used nationally. And it really helps the emergency rooms define staffing, define resources, and define prioritizing the delivery of care. So that's where we are. We had some starts and stops along our way. We actually collected a little bit of data and we did some sort of laborious handwork. At the time, we were on one EMR, and then in the middle of our journey, we, of course, transitioned to another EMR, and we've gotten a little bit sidetracked. And so most recently, with all of this discussion coming up again, I thought it would be worth sharing. And so, you know, my interest is, do we begin to try and create a single agreed-upon acuity scale that impacts all of us? And I think I'll turn it over to Pam.
Okay.
Thanks, Nancy.
Hang on one second, and we're going to bring Pam up. Just one moment. Pam, I got you. Just one second.
Okay, super. Well, good afternoon, everybody. As you listened, and as I listened to Nancy's presentation, and I've read it before, you'll see that many of the determinants or the factors that influence workload also are going to influence acuity. So they are tied together at some point. My presentation is brief, and it is pulled from the upcoming Orientation and Competency Text, Chapter 2, Organizational and Systems Role of the Ambulatory Care Nurse. Next slide, please. So there are numerous factors that impact and influence workload. In the old days, when we looked at needed more staff, how did we justify more staff? We really looked at time. And how much time did it take the nurse to do this? And if I did it X amount of times, then this is how many hours I need in a day or days in a week or whatever, and that's how we got our FTEs in some organizations. Time's just one factor, and you guys that work in ambulatory care, you know the kinds of patients that you see. Time's just one variable that we've got. Listed on the slide is a myriad of factors that influence workload and affect workload. And depending upon your clinic and the type of specialty and the types of patients that you see, there'll be other factors that influence workload as well. Next slide, please. So this slide just lists more activities. It's kind of scary when you think about what goes into adding up to workload. So it just lists more activities that can and do impact our work and our workload. And I am sure that I am missing many, many, many support activities and direct care activities that we do every day. Next. Again, just really do want to reiterate that time is not equal to workload, but it does and can impact workload. Also, efficiency of the work is not a good indicator of the workload for the RN. So you can't say, well, this nurse is more efficient, has less workload. It might be the type of work that they're doing or the way that they do their work. Each clinic and practice and organization captures and measures workload differently. They do it some way. As Nancy reiterated, we just don't do it consistently across the board. Raw numbers, those kind of time numbers and the volume numbers, the usual determinants that we use to measure work and staffing, they don't give us the whole picture. They don't help us capture the nuances of the practice, the complexity of the patient, and the complexity and nuances of the practice. Working in an infusion center is going to be different than working in a primary care center. If you work in a refugee clinic, that's probably different than working in a clinic that sees all third-party payers. It's different, and we don't have a good way to measure that. So I actually don't have good news for people. Next slide. So this is a list of some of the things that workload should include when we're looking at how to determine or how to measure workload. It's a partial listing of the tasks, the work, and the responsibilities that can effectively and accurately capture workload. How we capture that information and that data is problematic. Everybody's on a different electronic health record. If you're lucky enough to be on an electronic health record, you might be able to pull that information out. You might not be able to do that. Paper records is going to be harder. And so I actually don't have answers, but lots of questions and lots of fodder for people to think about. And next up is we're going to discuss an ambulatory acuity model.
You ready?
Yeah, go ahead.
Okay. Well, good afternoon, everyone. My name is Mike Callahan, and I have Jenna Butts with us. We are early on in this process, trying to figure out the ambulatory acuity model. So we do not have a lot of data to share at the end of this presentation. It'll be more what has went into our journey and where we're currently at right now. You can go ahead to the next slide. Okay, the James Cancer Hospital is an NCI, a designated comprehensive cancer center. We have 316 beds and growing rapidly. Actually, our hospital itself just moved into a new building about 3 years ago, and we had some shelled space that we were planning on building about 5 years from now, and we have grown so quickly that we're planning on opening up more beds next year ahead of schedule. In our ambulatory area, we have 19 exam clinics over 6 different sites in the city, where we see around 200,000 plus clinic visits. We've been growing about 10% annually in our outpatient visits, mainly due to when we moved from our old facility to our new facility, we gained a lot more beds, and we are planning on even growing more rapidly in the years to come. Next slide.
Okay, to give you some background, we actually had an existing model in place for a few years, and that model was based on the number of clinic hours for the physicians and APPs, and the RVU was the best guess at the number of nurses and PCAs that provider needed to use. And just to point out, when I say RVU, it's not the billing RVU that the physicians speak of. This is really just a measurement of the resources or the weight assigned to it. And so the issue with this model is that it was really just our best guess. We had no methodology of assigning how many nurses and PCAs should be assigned. And so over the years, the model became inconsistent and unreliable, and we really had no good measure of how to staff the clinics. And so because of this, senior leadership had asked us to standardize the staffing models across the different clinics. Next slide, please. And so the desired outcomes we had for this project, number one, was really to standardize the variable in fixed hours, clinic to clinic. But then another objective was that we wanted to standardize the clinic duties of the nurses, standardize the flow of the clinic, and also make sure the nurses were practicing at the top of their license. Another outcome we were looking for was to move from using subjective data to objective data so that we really could use this to make decisions on staffing. And then we also wanted to be able to proactively determine when staffing was going to be needed. And with the old model, it was a little bit hard to predict. Next slide, please.
Okay, so where did we start? Of course, like all good projects, we started with a literature search. Unfortunately, there is not any information that we found on exam clinics. It was more your infusion-based clinics, those type of clinical areas. So we struck out in that area, so we went back to the drawing board, and we started with 2 different processes to try to gauge what was happening in the clinic. One is we had some process engineers come into the clinic and observe and do some time studies, and then we went directly to the nurses to get their feedback by tracking, the old time tracking on paper, and then having them do their best guess at what the acuity of these patients would be. Furthermore, we had some separate group work on defining the roles and responsibilities of the clinic nurse, because what we found is from clinic to clinic, you had a wide variation of what the nurses were doing. So we went back and really started defining with each area the roles and the responsibilities of that clinic nurse. Obviously from those 2 things, we were able to identify inconsistencies in practice across the system. And then the last thing that we did was we went to a standardized reporting on call management from the EMR. As you know, in the ambulatory setting, it seems like phone calls dictate a lot of what we do, and we just had to figure out a way to try to capture that and run a report on those issues. Next slide.
Okay, so the challenges that we came across was, one, fully embracing the objectivity. Because this model had been in place for years, we were somewhat comfortable with it, even though it wasn't maybe the most accurate. And so we kept trying to just clean up the old model, but eventually we had to stop, completely abandon it, and start from scratch with the objective data. Another challenge that we found was inconsistent methods of data collection. One example is that when we were trying to capture the clinic volume and lab volume, we found that clinics were scheduling those appointments in different ways. So if a patient was coming in for a clinic visit and having their blood drawn, some clinics were scheduling those as 2 separate appointments, and some clinics were scheduling them as 1. And so we wanted to go pull the lab volume. It was very inconsistent clinic to clinic, and we found that that was why. Another challenge was RN feedback inconsistencies. As Mike had mentioned, some of what we did was we talked to the nurses to see how long they thought activities took, and sometimes they would say very different things for the same activity. We found that sometimes the nurses were maybe thinking of the worst case scenario, and that's why it was different, but then other times we found that they were doing completely different practices of this activity, and it was justified to have different times. Another challenge was physician inefficiencies. Every clinic has that one physician that runs a little bit slower, and so our challenge was, do we build that into the model and allow for the physician inefficiencies? Because we certainly aren't going to be able to change that. And then also discovering the variances in common practice. One example is clinic prep. We had gone to the nurses to ask how long it took to prep for a new patient. Some clinics it only took 15 minutes, others said it took 60 minutes. What we found was that those nurses that were only spending 15 minutes, they actually had a clerical person helping them, doing a lot of the prep work, and then they were just going through and double checking it. And so then we had to take a step back, and that's become a whole other project of defining what exactly clinic prep is and what the nurses should be doing. Next slide.
So one of the last things that was undertaken was one of our senior leaders had went out and done some benchmarking with some like facilities across the country, wanting to see what their intake and abstracting process was, what the RNs were assessing. So we did find that there was wide variations with what we had our nurses do versus some other facilities. And then we're looking at centralizing a call management system because the phone call piece is a huge piece of what happens in the clinic. And then finally, the subsets, we broke out into some committees exploring each of these areas. Next slide.
So the new model that we've landed on is based on true clinic volume, and the RVU is the time required for each activity by the nurses and PCAs. And so the variable components of this model are the number of new visits, the number of return visits, the RN-only visits, peripheral blood draws, port draws, the call management volume, and the procedures. And so we're able to predict how much staffing we'll need based on how much time we've associated with each of these activities. And then for the fixed time, we have the managers, the charge nurse, and then time for orientation, education, meetings, and any council work that they might do. And this is all pretty much standardized across clinics. There are some exceptions, but for the most part, it's standardized.
Okay, so where we're at now, like I said, we are kind of in the process and working through this, but we, once this work was completed, we shared with other leadership structures within the facility and gained their approval on it with their feedback. We sat down with each individual manager from the areas and described what we were doing and why we were doing it, and got their feedback from that. And then currently we are meeting with our medical directors for explanation of what we're doing and their buy-in, because in the clinic setting, they are so dependent upon our nurses and the frontline staff that they do become a bit protective over any changes that are made. So we wanted to make sure that we included them and really demonstrated that this is a much more objective manner to give staffing. Next slide. So in the future, we are communicating the change with the nursing staff, which I think is going to go really great because there was such a wide variation in how we staffed each clinic, and you would hear the nurses talk about, why did this unit have this many nurses and why does this unit have this many nurses? And there was, I think when we do fully implement this, there'll be much more buy-in from the nurses. We also, from direction of our Chief Nursing Officer, created an advisory group that will meet quarterly so that they can give us feedback to frontline staff on, did we take everything into consideration? Does it feel like staffing is better? Are we able to stay ahead of staffing needs? And then we're going to continue the subcommittee work that broke out from these individual activities that I had explained previously. Next slide. So what we know and what we learned along the journey was, for the most part, the existing staffing that we had was fairly justified in this new model. We had, in our old productivity model, we may have had a clinic that was running at what was deemed 130%, but the manager was like, I feel like we have enough staff, and so they went and request staff. So with this new model, it was much more close to that 100%. And so each area that we went to, it genuinely felt like we kind of hit the nail on the head. Productivity in most clinics did stay the same. We did have a few that either they had overshot the mark and it kind of reined it back in. And there were, I think, 2 areas that we were like, okay, we're going to have to keep an eye on this because it seems lower than what we expected. So far with our meetings with the physicians, it's been very positive feedback because it is objective data. And then we've identified opportunities for improvement in some of the clinic areas. And I think that is it.
Thank you very much. All right, we'll move on to our last speaker. And that's going to be our Stacey Clark.
Good afternoon, everyone. Thanks for letting us share our journey with you. I'll wait till we pull up the slides. So our journey has been very similar to the speakers before me. We really were struggling with how do we quantify the workload associated in each of the clinics. And so if you'll go to the next slide, I'll tell you a little bit about us. We are a large academic medical center in Dallas, and we have about 2.2 million outpatient visits a year. And just for a point of reference, all of our activities are decentralized. So all the clinics have a nursing staff that does all their phone calls and all the clinic work together. We don't have a centralized call center. Next slide, please. So our journey began because we really wanted to have a data-driven clinic staffing model. Similar to our colleagues before us, every clinic kind of developed their own workflows, their own staffing models, and there really wasn't a standard process that we could look to. So we wanted to focus also on workflows that kept the providers and the nurses to the top of their skill set or license. A big piece of that was also to help improve our turnaround time. Obviously, as our practice grew, our call volume and message volume and med refills also grew with it. One thing that we wanted to be really aware of, though, is that we didn't want to have any impact to moving through the visit. That was one of our lower scores on our patient satisfaction, and so that was really important to us to see if there were some efficiencies we could also gather through this process. And one of the most important things is that nurses really have a feel for what they need in terms of staffing, but we really need to develop some productivity standards that align with what our workload assessments were so that we could have some metrics that we could really kind of talk to the financial folks. So next slide, please. So what we did is we picked 5 pilot clinics, and we really wanted to have clinics where there were some champion leaders. We wanted to have clinics of different size and complexity. We wanted to have clinics that had both acute and some chronic patient management. And then we wanted some that had some in-office procedures. So just to get a flavor, some were surgical, some were medical, but we wanted to have a good mix. Next slide, please. So what we did is we did some similar things as the speakers before. We went in with a team and we really did a lot of baseline data collection. So we did chart reviews. We did surveys for both the providers and the staff on what was working, what wasn't working. We actually did observations or a little fly on the wall. We talked to some patients. And then we gathered some baseline data because we do use Epic. So we pulled a lot of information, and I'll talk a little bit more about that as we get into the data overview. And then we also developed some metrics that we wanted to really kind of have level loading of what our measurements were going to be. A big issue that we came up with and knew we'd have to address is the continued increase in volume of paperwork associated with the patient visits. So that was key for us to make sure we looked at that. Obviously, looking at patient satisfaction. Go to the next slide, please. And we also wanted to make sure, we missed one, but that's okay. So one of the things that we did, so that's okay, go ahead and do the next slide, is the baseline data. We picked one clinic that we worked with that was one of our orthopedic clinics, and so what we wanted to do on that baseline is for the call distribution, we wanted to really understand why were the patients calling in. So you can't just look at the reason for call, so we really actually went in and did chart audits. We had a team of nurses that went in and really sat down and said, why are our patients calling us? And as you can see, in this particular clinic, they struggled with just getting appointments and scheduling care. There was some care coordinations. But a lot of the things were the really symptom-based calls were not the highest priority, which was really enlightening to us. Next slide, please. So then we also looked at what is the workload. So we wanted to do some key type periods of the visit. So we did some studies where we looked at the intake for the patient visit. So that included things, our rooming functions for taking the vital signs, doing all those med recs, and finalizing the patient questionnaires and getting the history, those kinds of things. And then also the checkout. And what we found is that it was pretty consistent in all of the clinics that we did. Little tiny variances, but for the most part, on average, it was about 8 to 9 minutes to do both of those functions on the front and the back. So that was the calculation that we used for our final tool that we developed. Next slide, please. So we also tried to categorize the MyChart messages, the phone refills, and as everybody said before, there's not a lot of data out there. There are some metrics for some call centers. So what we landed on, and this was after both a combination of some literature search and also some observations, is that on average, it takes about 9.5 minutes to finish a call. Some are much longer than that, some are much shorter. But that was a good number for us when we were looking at data. So that's the number that we landed on, is about 9.5 minutes per message. Go to the next slide, please. So how did we really get buy-in for some of the changes that we were going to do? We knew that if we were really going to try to get all the clinics on board with having some standard, not only productivity standards, but staffing matrices, that we had to also really tell them that we were going to clean up some inefficiencies that came really out of the surveys that we did. So just wanted to kind of highlight some things that we did focus on while we were working on this project. In-basket messages, they're everybody's nightmare, but that was a huge issue for the nurses. Oftentimes in the clinic, the nurses helping in clinic, and then in between times trying to work on messages. So we really wanted to work on that flow, and we did come up with some things that we thought were really helpful to them. We really did better workflows for routing from the call center to the nurses so they got to the right people the first time, and the nurse wasn't having to pass messages back and forth. We also really did a better job of utilizing our pools, and we talked about that a little bit. That really wasn't something that in many of our clinics had spent a lot of time on, so we spent a lot of time on developing the right type of pool. Then also just simple clinic workflows. I mean, so in this particular clinic, they struggled with the surgery scheduling process and also the follow-up imaging process to make sure that those could be on time. So we developed some specific workflows for those and standardized some of the processes down to even helping them develop some standardized patient education packets for their surgeries. Each doctor had their own. We kind of helped standardize that, which was a little bit helpful for them. There was a very inefficient med refill process, so we actually used a third-party vendor that we implemented, and the information on that is really outstanding. What it does is really kind of combs the medical record for you for all those interesting data points that you need to know, whether you can fill it based on our standing orders here in Texas, we can do that. And so what that does is really speeds up that process. So significantly, in this clinic, we could reduce some of the turnaround time from over 400 hours, which is really kind of sad, to refill a medication down to the same day. So that was really, really helpful. Next slide, please. So the other thing that we really did is we focused on a whole process performed. And what we came up with is, especially in our surgical clinics, but also in some of our primary care clinics, they're spending an inordinate amount of time on prior authorizations, FMLA paperwork, those kind of things. So we actually developed a form encounter that's just going live right now, but it's really giving us some data points. How much really, anecdotally they can tell us, and we did some observations, we saved copies of these things, but to us it's really helpful to have that encounter type so that we can really track, is their volume increasing and what kinds of things. We also created an online FMLA standard form in EPIC. Since it's a federal form, that's the form we use, and we can pre-populate many of those areas based on the medical records, which is awesome. We also created for this clinic some standardized grids. For this surgery, here's how much time we're going to allow, which allowed us to do that as we schedule the surgery instead of having every doctor determine it. So there's always adjustments we can do to that, but the physicians really like that, so a lot of that is done on the front end. And then we just do training. It's really obvious that we need to have more training for everybody on the team, that's providers to staff, and really that was probably the biggest win out of all of this. Next slide, please. So I'm going to tell you what came out of this journey, and we're continuing to do it, as we say. But for this particular clinic that I'm sharing today, we used business hours because that was the other complaint. They didn't want to be measured when the clinic was closed, so we said, fine, we're only going to measure basically 8 to 5 Monday through Friday. So that'll be our time commitment that we're going to do. So when we started with this clinic, their average time from open to close was 35 business hours, which is really sad because that's almost a week. But as we've come through this journey in the workload, they're down to 13.7 hours on average, so that's really great. Next slide. So we also have our MyChart encounters, which once again is a whopping almost 48 hours turnaround time business hours, and we're down to 15. It's not where we need. We know we can't close everything right away. We're waiting on physicians, but it's a huge improvement. Next slide. So we also wanted to capture how are we moving our patients through the visit. So we use a metric that we call the adjusted dwell time. And all that really is, it looks at the start of the appointment time. So we don't, it was very aware the physicians didn't want to be held accountable if the patient got there early. So all we're talking about is the time the appointment starts to the time they check out, and then you deduct the appointment length time. So, for example, if a patient's appointment starts at 8 o'clock and they check out at 9 o'clock, but their appointment is a 30-minute appointment slot, their adjusted dwell time is 30 minutes. It's that extra time they're in the clinic. And as you can see for ortho patients, and there is going to be some surgery scheduling, there is some extra time that's going to be outside of the visit. But we are at over an hour of this extra time on average, which meant some of our patients were spending a very long time, and some were spending maybe a shorter time. But now we're down to about 49, and it has actually continued to drop. I just got the latest data point for this next month, so it's going in the right direction. Next slide. For patient satisfaction, I think we have had some great impacts. These are our last 2 data points that we had. I'll update it when the next reports just come out. But what it really did, we didn't see a huge amount of change in terms of our promptness in returning phone calls, but we did see a huge amount of increase in our wait time in our clinic, and we also saw a big increase, as you all know, every little increase is significant with press gaining, for the concerns of the nurse. And so I think that goes back to getting back to them promptly maybe a little bit more. Next slide. So here's just kind of an overview of where we were in terms of that MyChart and telephone encounter. We made progress in every clinic, every pilot clinic we did, significantly in many of them. As you can see, I'm not really proud to say that our response time was not that great to begin with, but we really reduced it significantly. Next slide. So what did we do with all this data? What we ended up coming up with is really, for us, we came up with some metrics and some productivity standards. So essentially what we say, we're using that it takes about 1 RN for every 1,000 to 1,100 messages on average. Now there are some things we can look at that, but we really felt that that's actually pretty accurate, and so that's the metric that we use. We kind of assigned those basic things that pretty much went across all clinics in terms of simple teaching, patient teaching, medication administration, care coordination, those simple things that the nursing staff will need to do. And that calculated it out to about 1 licensed staff, and it depends on the clinic. We use both RNs and LVNs in our practice here. But it's about 1 full-time licensed staff to about every 4 clinical FTEs. and one clinical FTE is 10 half-day sessions, so that's how we calculated it. Now, what we do have for those other procedures or some extensive education, those kind of things, we have some formulas, and I'll show you on the next slide when we get to that, how we calculate that in to capture that workload. Same thing with MOAs. We know that based on our average, an MOA, we need about 1 for every 15 to 20 patient encounters in a session. And so that does not include any of the minor procedures that may have, and we account for that differently too. And then we actually have a whole metric there just for paperwork, because that seems to be such a significant amount of work. Next slide, please. So what we came up with is a tool that has formulas built into it, and so what we do now is we're going clinic by clinic, and we're actually kind of pre-populating, talking to them a little bit. But essentially, you can see above, we capture their phone, MyChart, and refill information, and then it calculates what is the workload FTE needed for that workload. Same thing with the clinical FTE, so once we put in how many providers they have, a lot of times we do this by pod, it may not just be the entire clinic. It'll calculate the nursing load, and then we can put in nurse visits, we can put in procedures that we have to do based on CPT code, so we fill in the blanks, so to speak. And at the bottom, what it really does is gives you an overall calculation of the FT, and that's really where we have the discussion back and forth. We do calculate the non-productive time in there as well, and so that it kind of gives them a global kind of overview of what's your workload. This is really where we have some good discussions, and I will tell you, the clinics that we've gone through with this exercise so far, it's really pretty close, and so we think that it's a good way for us to kind of document and have some consistency between our clinics. And we use it in our budget process. If they want to request another FTE, they use this tool now to help document and their needs. So it's been working for us. So we're just starting the journey, and we've got some good data so far, but hopefully we'll be able to continue and maybe give you some more results later. So that's really it for my presentation, and I think now we're really ready to open it up to anybody who has questions.
Thanks so much, Stacy. Thanks so much. So just a real quick on some of the questions, some similarities. All of these slides will be available in the leadership SIG, as well as the recorded session from today. All right. So we have a question here from our Jen Sarkazan. I'm probably saying it wrong, but are they using Epic as an EMR? And if yes, how are they compiling data? What kinds of encounters and reportable fields do they use to quantify nursing work? And I believe this is probably, maybe could be answered by any of the speakers. I'll give it to the speakers to decide.
Well, I can talk about what we have pulled from Epic. We have a couple of reports in Epic on our telephone encounters, MyChart encounters, and refill encounters. We sort them by the categories. If they're scheduling, that's not counted in the queue, so that's the message report that we do. Some of the other calculations that we pull is we do pull some CPT codes or some out of Epic for some of the procedures that the nurse or the MOA does assist with.
Thanks.
This is Nancy at Yale. We also are on Epic. We do a lot of reporting as well directly from our pools. We've, done a lot of stratification of reason for calls, message types. We've designated specific triage pools, coordinating nurse pools. We have turnaround time reports on time messages received to a final act. Various different things. So yes, we are using Epic. It sounds easy. It took us a long time to get them, though. For those of you.
The James also uses Epic, and we looked at the number of completed visits, and then for the procedures, since we run productivity on a biweekly basis, about 10 days after the last date, we pull the procedures based on the orders placed, so that it's independent of the providers closing the encounters. So originally we were looking at using charge data, but that volume was too low because we were on such a time constraint.
Looks like the next question is for our Ohio State folks. This is from Sue Weiss. She asks, will the model you developed and implemented, with the model you developed and implemented, did you see an increase in FTEs and staffing budget? Was this difficult to justify, or did you have too much staff?
For the most part, it was kind of where we thought. There was a couple of clinics that we anticipated we needed help, and to be honest, our old productivity model was very suspicious, so we have a committee that approves positions. They were not willing to grant those positions through until we finished this model, and once this model came through, it did indicate that we needed more staff in these areas, so we were able to secure, I think, 2 to 3 additional nurse positions throughout, but for the most part, it stayed the same.
And we'll be able to use this model to budget for next fiscal year, and so we'll look at it, and finance will predict a 3% growth. We'll be able to plug that into the model and see how many FTEs that equates to, clinic to clinic. Thanks. All right, the next question is from our Joan Pataya. I believe this is for any of the speakers. If you could select the top 3 things to do in starting in this journey, what would you suggest?
Well, that's a loaded question. I think really working with your data teams, you have to have data. That's really the key thing. I think, and you have to really kind of focus on some metrics. So that's what we focus on a lot with the data collection piece. It led us into a lot of other areas to explore. I think similar to what happened in Ohio State. But I think that's the key that I would say.
Yeah, I would agree, and also making certain that we're talking the same language when we use a term, that what we say for Clinic A is going to mean the same for Clinic B, but getting the data, the ease of pulling the data, and then hopefully having somebody to help you interpret the data.
Because once you have the data, you can really develop the methodology, and then you can replicate that, but it's really having that to help you make those decisions.
This is Jenna, and I'm actually the data analyst for the Janes who built the models. And I think what was most helpful for me is that I actually followed a nurse in clinic for a day and saw what she does and was able to see the terminology she uses, and I was able to better pull the data and knew exactly what we needed to capture. So that was very helpful for me. Thank you. Another question. This one's for Stacy from Angela. Is surgery scheduling and education completed by the RNs in the clinic, and was that considered in calculating FTE needs in the ortho surgical volume?
So they have a mixture that goes back to those wonderful decentralized approaches. So we did recommend some standardization, and they're moving toward having everybody use a surgery scheduler. We do have another line that we've added to the form that actually captures that workload as well, so we can tell when we need another surgery scheduler. But if the nurse was doing it, we captured it on a separate line item so that we could capture it. And we basically looked at how long it took for them to do surgery, the pieces of surgery scheduling, and then we just used that times the volume of surgeries to schedule per month.
Thanks. Another question from our Joan. Actually, there's 2, so we'll see if we can go through these quick. There's a triage section of EPIC. Are any of the speakers using this element to triage unscheduled visits?
We do use the triage module in EPIC for symptom-based calls, so we do use those. As part of this project, I didn't speak about it, but we also developed some very clinic-specific protocols that have embedded orders in them. A lot of them, I don't know if many of you know the EPIC triage module, a lot of them aren't as robust with some standing orders. So we did that for when we looked at our frequency of calls, we were able to identify a lot of times the top 5 to 10 reasons for those kinds of calls, and we could develop some clinic-specific protocols.
Great. Another question. Are any of the speakers using their CPT ICD-10 coders to provide guidance on the top reasons for visits in the various clinics?
We did not. We just pulled that from the diagnosis that was assigned by the visit, but we don't have coders in most of our clinics.
same.
Thank you. Another question from Lisa Thornton. Can you explain how to use the Acuity to adjust staffing? What frequency, etc.?
So I can speak to how we're trying to target this. Because we're very decentralized, every department actually has their budget for their clinic. We usually do this more on an annual basis, but there are some times in the middle of the year if their volumes increase or decrease, but usually increase, that they will get some adjustments at that time. The next step would be, we do have a float pool. We never have enough nurses or MOAs in that float pool. That would be the next step, to be able to look at a little bit more of a variable aspect for some of those areas, but that's just where we are in our journey.
Another question, is anyone using certified nursing assistants in the clinic setting? And how would that be a part of the Acuity?
So we use certified medical office assistants. So that's what we use. So we don't have a CNE kind of component. So that's what we use.
Yeah, and this is Nancy in Connecticut. We also use certified nursing assistants, but we don't really recognize. They don't really have a licensure, and their practice is very limited. They don't do any. They really may not. They can't do any assessments or injections or teaching. So it really does not fall into the acuity of the nurse workload. It's just their rooming intake function.
Thank you. There is no other questions on the chat at this time. Chris, I'll go back to you.
So I want to thank everybody again for participating. Are there any topics that particularly would jump out at anybody that we'd like some follow-up on, or is it helpful to continue to identify different models from around the country to share with you? I'd like your thoughts on that.
Chris, there's one other question popped up. Maybe this might have part to do with that. Most organizations have hired upper-level coding experts that population health clinics use extensively, and working with clinics developing new flows and processes as well as clinical practice guidelines, and identified a significant number of areas that helped with data collection. So I guess that's the thought right there in the population health clinics. And I think that's about it on questions. We are at 3:02.
Well, I know we're at the end of our time. I'm going to go ahead and post we'll make sure that may not be me and Valerie, Cynthia, but we'll get this discussion posted for you. Well, I'll send you out maybe a short survey monkey, but maybe if you could be thinking on additional topics or what you'd like to have in the future, what would be the most meaningful for your practice, so that we can really help you on your journey. And with that said, I'd like to thank everybody for their participation. The presentations were fantastic. Cynthia, thank you for coordinating. Diane, you did a great job coordinating the speakers. It was just truly a team effort, and really like to thank everybody for all their help in making it happen. So unless there's any last comments, we will get some follow-up out to those that have been on the call, and want to thank you again for participating.